Hola, buenas tardes. Vamos a empezar este simposio que va a tratar 3 temas de actualidad en el fracaso renal agudo. Para ello contamos con 3 importantes ponentes. La doctora Marglie Osterman trabaja en el Hospital Guy's St Thomas de Londres. Ella es una nefrointensivista con un especial interés por el cuidado de la patología renal del paciente crítico y nos va a contar si es posible prevenir la progresión del fracaso renal agudo en la enfermedad renal crónica y cómo hacerlo. El segundo ponente, el doctor Liaño, no necesita presentación. Ha desempeñado toda su actividad asistencial y científica en el Hospital Ramón y Cajal y ha luchado como nadie para que el nefrólogo participe activamente en el manejo del fracaso renal agudo en las unidades de cuidado intensivo. Y en esta ocasión nos va a hablar sobre cómo optimizar la diálisis intermitente en estas unidades, que yo creo que también es de gran trascendencia para el nefrólogo. Por último, vamos a tratar si es posible la aplicación o si merece la pena la aplicación de los Big Data en el fracaso renal agudo. Para ello contamos con el doctor S.E.N, intensivista, gran conocedor del tema, profesor del Departamento de Cuidados Críticos de la Universidad de Alberta de Canadá y que ha desempeñado gran parte de su actividad científica y asistencial en el manejo del fracaso renal agudo en el paciente crítico. Les recuerdo a la audiencia que pueden hacer preguntas a través de su ordenador utilizando el lápiz que tienen en la parte derecha de su pantalla y que por favor hagan las preguntas ya conforme empiecen las presentaciones para que cuando acaben ya podamos disponer de ellas. Y sin más, empezamos este simposio. No sé si Esteban, ¿quieres comentar algo más?
No, simplemente agradecer a todos los ponentes. Thank you for joining. Thank you for the presentations. And this will be a great symposium. We will have the questions, las preguntas al final de todo. Muchas gracias.
Gracias.
Good morning, good afternoon, wherever you are in the world. It's a great honor to contribute to this Congress. I would like to thank the organizers for inviting me. In the next 15 minutes, I will explore whether we can prevent the transition from AKI to CKD. These are my disclosures. They have not influenced this presentation. Acute kidney injury is a multifactorial disorder with many different etiologies and many different trajectories. And as shown here, some patients recover kidney function very quickly, others take longer, and a proportion of patients, unfortunately, does not recover kidney function and develops chronic kidney disease. In addition to chronic kidney disease, we also know that survivors of acute kidney injury have a higher risk of other long-term complications, in particular cardiovascular and cerebral vascular morbidity. So the question is whether we can influence this. It should be remembered that acute kidney injury is a pro-inflammatory condition, where after the trigger and onset, various different inflammatory cells and inflammatory pathways are activated. And their role is to repair and heal the insult. And very often this leads to the full generation and regeneration of nephrons and renal tubular structures. But occasionally, some nephrons will undergo maladaptive repair and can be completely destroyed and vanish. And so this balance between processes that induce healing and processes that can ultimately lead to fibrosis is very fine. There are different pathophysiological mechanisms that contribute to the development of fibrosis and the development of chronic kidney disease. In particular, glomerular hyperfiltration, reduced capillary density, and activation of pro-fibrotic processes. Furthermore, we know that the risk of CKD is higher in patients with more severe acute kidney injury, with more prolonged acute kidney injury, and in patients with recurrent acute kidney injury. And finally, it is higher in patients with impaired pre-existing renal function. So to prevent the transition to CKD, the most important thing would be to prevent acute kidney injury altogether and to prevent recurrent acute kidney injury. But the question is whether there are any other strategies. Are there any magic drugs or magic interventions that induce renal recovery and prevent chronic kidney disease? For the last decade, we've debated whether the practice of renal replacement therapy plays a role. And certainly in this paper by Professor Wald and colleagues, they argue that intermittent hemodialysis may be nephrotoxic. They analyzed the data of more than 13,000 patients who had had either continuous renal replacement therapy or intermittent hemodialysis for acute kidney injury during a 14-year period. And as you can see at the bottom, in patients who had received continuous renal replacement therapy, their 90-day survival was lower compared to intermittent hemodialysis. But at 1 year, there was a significantly lower risk of chronic dialysis dependence. In contrast, patients who had received intermittent hemodialysis and survived had a 1 in 4 chance of being on dialysis at 1 year. And the authors argued that intermittent hemodialysis was potentially nephrotoxic and led to a much higher risk of becoming dialysis dependent. In contrast, this team from the University of Pittsburgh argued that it was not so clear-cut. They analyzed the data of 638 patients who had received renal replacement therapy in the intensive care unit during an 8-year period, and all of them had left hospital alive. When they looked at their outcome, they noted that patients who had received continuous renal replacement therapy had a better chance of kidney function recovery and being off dialysis at 90 days. But at 1 year, there was no significant difference between the two groups. And if the replacement therapy modality was chosen based on the existing hemodynamic, then renal recovery at 1 year was no different between intermittent and continuous renal replacement therapy. So the current evidence is not completely conclusive. And so a team of experts got together in 2016 and looked at the role of renal replacement therapy with regard to promotion of renal recovery. And they asked the question whether different factors related to renal replacement therapy were potentially harmful or contributed to the development of chronic kidney disease. They focused on the list of factors as shown here, including modality, anticoagulation, but also hemodynamic stability and dose of renal replacement therapy. And following review of the data until 2016, they concluded that there was no convincing evidence, but there were data suggesting that maybe intermittent renal replacement therapy may delay renal recovery. But again, the existing evidence is inconclusive and not always confirmed. And they also pointed out that different studies had shown that hemodynamic instability and hypotension were harmful and potentially delayed renal recovery and could provoke the development of fibrosis. And this meant that processes related to, for instance, fluid balance or temperature of the dialysate, which may be associated with more hypotension, could also possibly lead to delayed renal recovery. But at this time, the evidence for these different aspects of renal replacement therapy are still at an early stage and not fully conclusive. The next question is whether there are any drugs or pharmacological interventions. And this was the objective of the analysis by Professor Dong and colleagues. They reviewed the existing data and identified various drugs, as shown here, that had been tested in experimental animal models. And all of these drugs had some connections to different inflammatory pathways. And although some of these drugs were beneficial in animals, the team showed that there was no data suggesting that they had a role in humans and in human clinical practice. So we're left with the fact that at present we have no clear specific therapies to induce renal recovery and prevent prolonged fibrosis and chronic kidney disease. Anything else we could do? Well, this is the first randomized controlled trial looking at the role of comprehensive follow-up of AKI survivors. It was conducted in Thailand and has just been reported, and the team should be congratulated for conducting the first randomized controlled trial in this area. They recruited patients who had had acute kidney injury stage 2 or stage 3, and then randomized them to either usual care versus comprehensive multidisciplinary follow-up for 12 months. And the comprehensive follow-up consisted of follow-up by nephrologists, nutritionists, and pharmacists. In total, they included 98 patients and had data of 78 patients available at 12 months. And that's clearly demonstrated here. Patients who had been followed up using the multi-professional team had much better dietary recall and a much better drug reconciliation compared to patients who received usual care. Adds to harder outcomes at 12 months, as shown here, patients who received comprehensive multidisciplinary care had a lower degree of proteinuria and better blood pressure control at 12 months compared to patients in the usual care arm. All other outcomes were also better in the comprehensive care arm, but the differences did not reach statistical significance. And so the team concluded that comprehensive multi-professional follow-up was possible and appeared to be effective at reducing proteinuria and achieving better blood pressure control. And these findings certainly support the conclusion of this paper by Jay Coyner and colleagues, where they argue that survivors of acute kidney injury are high-risk patients who deserve to be followed up. And as a minimum, the authors argue, they need their protein level checked at 3 months and undergo GFR measurements. And then subsequent follow-up should be individualized based on risk factors and comorbidities. And in this paper, they make a strong case for patient and caregiver education and feel that this is a key mainstay of post-acute kidney injury care. So if we accept this, if accept education and follow-up are important, then it's important to pass on the information and to inform primary care physicians, family doctors, and general practitioners. And sadly, I know from this doesn't always happen. In this paper from France, the team looked at the information provided in hospital discharge summaries. So if we agree that education and follow-up are important, then it is clearly important to pass on the information and to inform the primary care physician the general practitioner, and the family doctor. Sadly, this doesn't always happen, as shown here in this study, where the team looked at the data provided in discharge summaries. As you can see here on the right, only 36% of discharge summaries from the intensive care unit included important information of patients who had had acute kidney injury. And a recommendation to make a referral to a nephrologist was only included in less than 3% of discharge summaries. Together with colleagues, we also looked at our own data, and we focused on patients who we considered to be at highest risk of chronic kidney disease. For this purpose, we focused on patients who had had acute kidney injury stage 3 and treated with renal replacement therapy in the intensive care unit. And then we identified all patients who had left hospital alive. When we explored the information in the ICU and hospital discharge summary, especially with regards to the information about acute kidney injury, need for renal replacement therapy, and recommendations for follow-up. And then lastly, we looked at outcomes at 1 year. And as shown here, only just over 50% of discharge summaries were complete and had the relevant information about acute kidney injury, renal replacement therapy, and follow-up management. And the proportion was significant in patients who left hospital with a hospital discharge summary. And not surprisingly, in patients who had complete hospital discharge summaries, there was a much higher chance of a nephrology follow-up at 1 year and a much higher chance of a repeat creatinine measurement and proteinuria estimate. So it is important to pass on this information as a prerequisite to facilitate follow-up of this high-risk patient population. So in summary, the aftercare after acute kidney injury really aims to prevent recurrent episodes of acute kidney injury and to identify patients at highest risk of chronic kidney disease. I hope I've shown you that this is a multi-professional, multidisciplinary strategy. Different caregivers contribute and collaborate. At present, our existing data and evidence is still very sparse, but we know it's necessary, and we know that more knowledge is needed, and hence more research and also randomized controlled trials are important in this area. So in conclusion, the risk of chronic kidney disease after acute kidney injury is higher in more severe and more prolonged acute kidney injury. And obviously the best strategy to prevent CKD would be by preventing acute kidney injury. In patients who develop acute kidney injury, multiple factors contribute to CKD, in particular maladaptive repair and pro-fibrotic processes. To date, there is no specific therapy to promote recovery and prevent fibrosis. But we have evidence that a comprehensive, individualized, multidisciplinary strategy, taking into account patients' comorbidities, is associated with better outcomes and better cardiovascular management. And we also have evidence that the information transfer between hospitals and primary caregivers is not ideal. And this is absolutely essential in order to improve the outcome after acute kidney injury. Thank you very much for listening.
Buenas tardes a todos. Quiero agradecer a la S.E.N por haberme permitido estar con ustedes esta tarde y hablar de cómo optimizar la diálisis intermitente en las unidades de cuidados intensivos. El tema es complejo, pero me bastaría con que ustedes leyeran estas 4 palabras: fontanería, conocimiento, empatía y disponibilidad, para decirles que con que se queden con esto pueden ir a otra ponencia que esté en este momento en curso, porque ya han atendido prácticamente a toda mi charla. Con respecto a la fontanería, quiero señalarles que es un aspecto importantísimo. Debemos en las unidades de cuidados intensivos tener una toma de agua accesible, un drenaje que nos permita hacer el tratamiento de aguas y así finalmente poder proceder a la diálisis intermitente. Sin esta cosa tan sencilla, una toma de agua y un drenaje, es imposible hacerlas. Conocimiento. Pues el conocimiento obviamente es necesario en cualquier técnica, y el conocimiento de los nefrólogos aquí es importante, porque de alguna manera llevamos la diálisis, que nos la han metido como en un chip dentro de nuestra genética. Y permítanme que les hable, y les voy a hablar para hacer este mandato que me han encomendado, hablar un poco de nuestra experiencia en el Hospital Ramón y Cajal. Aquí les presento desde el año 85 hasta el año 2014, 3 décadas, los pacientes atendidos por nosotros en las UCIs del hospital. Observen cómo desde el año 1985 a 2014 ha habido un incremento en los pacientes atendidos del 1.200%, que suman un total de casi 3.600 pacientes en ese periodo. Muchos de ellos habrán dializado, otros no, pero posiblemente cuando nos han requerido es porque necesitaban diálisis. Y como siempre que se cuenta una historia hay que tener en cuenta, o se tiene en cuenta por parte de los historiadores, un hito, pues entonces el hito que yo he encontrado dentro de la literatura nuestra es un hito en el año 1996, cuando el doctor Drum en Viena escribe: la insuficiencia renal está cambiando desde una afectación monoorgánica a otra situación en que el fracaso renal agudo aparece en el contexto del síndrome de disfunción multiorgánica o fallo multiorgánico. En este momento podemos decir que cuando las unidades de cuidados intensivos y los intensivistas empiezan a tomar un papel ya consolidado en el manejo de este tipo de enfermos. Y hasta esa fecha, hasta 1996, ¿qué habíamos aprendido? Pues habíamos aprendido a manejar diuréticos, que la noradrenalina podía usarse en estos pacientes, que la nutrición del paciente era importante, que podíamos fabricar unos artilugios con monitores viejos de diálisis para hacer las técnicas de depuración. Y entonces la industria se acordó de que la insuficiencia renal aguda existía y fabricó monitores para las técnicas continuas de reemplazo renal. Y surgieron estudios epidemiológicos y entonces aparecieron las preguntas relacionadas con la diálisis. ¿A quién, cómo, cuándo, cuánto y dónde dializo? Y para todos nosotros que somos españoles, pues esto nos suena a un bolero: a quién, cómo, cuándo y dónde. Y realmente estamos ante el bolero de la ira. Y permítanme la ironía de decir que no les voy a cantar el bolero de la ira, porque en el tiempo que tenemos no nos da para responder a todas estas preguntas. Sin embargo, recientemente, en el 2017, el doctor Baxau y el doctor Gaudry en Intensive Care Medicine, recientemente, este mismo año, la doctora Valdenegro en Nefrología, en nuestra revista, contestan a todas esas preguntas del bolero con mejor música que la que yo pudiera poner. Y obviamente hay que recordar las guías Cadigo sobre el tratamiento de la insuficiencia renal aguda, donde dicen, señalado en rojo, que el uso de la hemodiálisis intermitente o las técnicas continuas son terapias complementarias para los pacientes con fracaso renal agudo. Es imposible resumir esta diapositiva, que está en ese artículo que les acabo de mencionar, del Dr. Baxow y colaboradores, en el cual nos cuentan las características principales de la diálisis intermitente, de diálisis híbridas entre continuas e intermitentes, de la diálisis continuas y de la diálisis peritoneal. Pero vamos a soslayar esta diapositiva. ¿Cómo se hace el tratamiento sustitutivo? Pues evidentemente en la IRA, pues, para aquellos pacientes que lo necesiten, hay dos condicionantes. Hay dos condicionantes, uno son cómo está la hemodinámica del paciente y la otra las posibilidades técnicas de las que tenemos. Si el paciente está con estabilidad hemodinámica, podemos tener y tenemos esas características de posibilidad de hacer la hemodiálisis intermitente en las UCIs por aquellos aspectos relacionados con la fontanería, entonces debemos de seguir allá por estas vías. Si hay imposibilidad logística, aunque haya estabilidad hemodinámica, tendremos que recurrir a las técnicas de depuración extracorpórea continua. Y cuando el paciente está inestable hemodinámicamente, es recomendable recurrir por presencia de sepsis o de otras circunstancias, pues a las técnicas continuas. Luego hay cambios. Y en este respecto, quiero presentarles cómo son los flujos intertratamientos que podemos tener en los pacientes con diálisis. Las flechas verdes indican el tratamiento inicial con técnica continua, con hemodiálisis intermitente o con técnicas híbridas. El grosor de la flecha indica un poco el número de pacientes que van a utilizar esa técnica como terapia inicial. Luego hay una serie de flujos que pueden pasar de unos a otros, que de alguna manera, como van a tener acceso a esta presentación, les queda reflejada con este pequeño texto que les pongo aquí. Lo que quiero llamar la atención, y se lo remarco aquí con esta aparición de la misma diapositiva, pero con otro tono de color, en rojo, pues, como la hemodiálisis intermitente es una posibilidad real en las UCIs y cómo esa hemodiálisis intermitente además van a ser los tratamientos en aquellos pacientes que sigan necesitando tratamiento renal sustitutivo al alta de la UCI que van a tener que seguir, en general, hemodiálisis intermitente. Y cómo esas técnicas caen un poquito más dentro del campo del nefrólogo que también conoce, maneja y hace las técnicas continuas, también como lo puede hacer la hemodiálisis intermitente, tiene además estas habilidades técnicas debidas a su formación. Y en este sentido, estos son los tratamientos iniciales de los pacientes atendidos en 6 años, del 2015 al 2020 en nuestro hospital. ¿Cuál fue el tratamiento inicial? Pues en las UCIs, con técnicas continuas el 45%, con hemodiálisis intermitentes el 33%, y con ambas técnicas en algún momento se aplicaron al 22% de los pacientes. Hasta ahora hemos hablado de los pacientes y de las técnicas. Ahora, en esta diapositiva, les muestro en estos años, de esta década, del 2011 al 2020, el número de sesiones de tratamiento renal sustitutivo en las UCIs del Hospital Ramón y Cajal. En verde es el sumatorio de las dos técnicas, en rojo es el número de sesiones realizado en los enfermos críticos en nuestro centro, y en azul el número de sesiones de tratamiento renal sustitutivo con técnicas continuas en nuestro centro. Siempre han sido más las sesiones con hemodiálisis intermitentes que con técnicas continuas. Y llamar especialmente la atención que en el año 2020, cuando nos golpeó la pandemia, el juego de las técnicas intermitentes de diálisis supusieron una disponibilidad que en otro caso no hubiéramos tenido y hubiera constituido un problema de manejo. Así pues, quiero resumirles a ustedes presentarles, mejor dicho, que nuestra forma de tratar, disponiendo de ambas técnicas en las UCI, es una manera inclusiva del tratamiento renal sustitutivo en el paciente crítico, y creemos que es mejor para el paciente por el conocimiento profundo de las técnicas dialíticas y la experiencia de su manejo que el nefrólogo adquiere por su formación y por nuestra experiencia a lo largo de todos estos años. Que el personal de enfermería nefrológica goza de un entrenamiento de las técnicas dialíticas que, en general, que tienen una capacidad versátil en su manejo para poder hacer otros tratamientos complementarios complejos con una relativa facilidad que a lo mejor otras enfermeras no disponen por falta de continuidad, como pueden ser las diálisis hepáticas o plasmaféresis u otras. Y luego una cosa que es muy importante es que la posibilidad de darle la técnica depurativa adecuada a la situación del paciente en cada momento nos parece una ventaja tremenda para el mismo. Y es muy importante porque planteamos un programa colaborativo entre los equipos tratantes, intensivistas y nefrólogos de manera complementaria. Además, nuestro modelo tiene ventajas para la institución. Suponen un ahorro económico, mejora la cartera de servicios del hospital y aporta ventajas logísticas. Este es un trabajo que presentamos antaño en el 2017 en la EDTA, en que veíamos, aquí les muestro las dos posibilidades, lo que estábamos haciendo nosotros, el número entre los años, aquí es un periodo analizado entre 2006 y 2013, donde se hicieron 2.400 hemodiálisis intermitentes, unas 1.800 técnicas continuas. Aquí les pongo el coste por sesión, hacer un inciso, decir que por razones varias, aquí solamente se han considerado el gasto del material fungible. Las máquinas eran un poco antiguas, estaban amortizadas, funcionaban perfectamente, pero estaban amortizadas, y el gasto que supuso desde el punto de vista de material fungible, como digo, tanto con la hemodiálisis intermitente como con las técnicas continuas, que representaron un costo de 1 millón de euros. Bueno, pues si no hubiera habido hemodiálisis intermitentes y suponiendo que de estos 2.400 sesiones solamente hubiéramos tenido que aplicar 2.000 más como técnicas continuas, el incremento en el coste hubiera sido muy alto. De manera que nosotros con este sistema a lo largo de este tiempo hemos ahorrado prácticamente 1 millón de euros. Creo que puede haber matices sobre esto, pero las técnicas intermitentes complementariamente al uso de técnicas continuas de diálisis suponen un ahorro para la institución. Y la logística, esta es una cortesía del doctor Gainza, en una unidad de cuidados intensivos de su hospital, vean cómo supone un esfuerzo logístico y antiestético cuando no se emplean técnicas de hemodiálisis intermitentes. Así que, ¿cómo podemos optimizar la diálisis intermitente en la UCI? Lo primero, hay que recordar que el objetivo del médico es el bien del paciente. Y para ello, nefrólogos e intensivistas, o intensivistas y nefrólogos, deben colaborar en su manejo, que sea consensuado, considerar los criterios del otro especialista, valorando, y aquí ven que lo pongo en letras muy pequeñas, los intangibles. Y pongo en letras muy pequeñas los intangibles, porque los intangibles muchas veces no se ven y sin embargo son muy grandes. Casi con seguridad podemos decir que los intensivistas tienen más experiencia que nosotros en el manejo hemodinámico de los pacientes Y nosotros tenemos más experiencia que los intensivistas en el manejo dialítico de los pacientes. Yo creo que aceptando las potencialidades del compañero especialista de otra especialidad es beneficioso para el enfermo. De manera que también habría que fomentar la empatía entre dichos especialistas, mejorando la interrelación entre las personas de cada equipo y hacer trabajos y publicaciones en común. Y la última cosa que ya les dije al principio de la charla, para mejorar, optimizar la diálisis intermitente en las UCIs, lo que es fundamental es que haya una disponibilidad nefrológica las 24 horas de todos los días del año. Debo reconocer que en algunos hospitales pequeños esto es difícil de conseguir. Hemos visto el cómo, pero no solamente hay un cómo para utilizar diálisis intermitentes, hay también un porqué. Y ese porqué se pueden resumir en las dos diapositivas, esta y la que continúa, porque lo que es evidente es que es más confortable la hemodiálisis intermitente, especialmente cuando está consciente y no está sedado el paciente, porque la diálisis continua se soporta muy mal el frío. Porque permite una mayor dependencia de la técnica depurativa para facilitar la movilidad hacia pruebas diagnósticas, hacia otro tipo de tratamientos, como pueden ser cirugías, rehabilitación del paciente, etc. Porque conllevan menor dialitrauma y porque en situaciones de urgencia extrema pueden ser mucho más, son mucho más rápidas para el control de las alteraciones electrolíticas como una hiperpotasemia, etc. Y además disminuye el gasto hospitalario, optimizan los espacios, posibilita el uso de técnicas híbridas y el destete de las técnicas continuas cuando se puede, cuando mejora su situación hemodinámica. Un aspecto que no está citado en la literatura, pero que es fundamental, contribuye a preservar los vasos sanguíneos en previsión de la necesidad de una fístula arteriovenosa para las hemodiálisis crónicas, un aspecto que es especialmente cuidado por parte del cuerpo nefrológico. Y una cosa muy importante que hemos visto recientemente, aumenta la disponibilidad de opciones terapéuticas con tratamiento renal sustitutivo en situaciones excepcionales, como ha sido la pandemia por COVID-19 en el 2020. Y, como les decía al principio, para optimizar la diálisis intermitente en las UCIs, era lo que les dije: fontanería y tratamiento de aguas. Conocimiento y razonamiento basado en la evidencia para atender al enfermo y hacer las indicaciones oportunas de la técnica. Fomentar la empatía entre especialistas y su colaboración para un objetivo común, que es el paciente, el beneficio del paciente, y tener una disponibilidad nefrológica las 24 horas de todos los días del año. Entonces, ya para finalizar, quiero resumirles que lo que dicen las recomendaciones de la guía KDIGO sobre el tratamiento renal sustitutivo es cierto. El uso de la hemodiálisis intermitente y de las técnicas continuas de reemplazo renal es complementario y permite ofrecer el mejor tratamiento al paciente según su situación en cada momento. Y ahora ya sí que, para finalizar, quiero dar las gracias, en primer lugar, a ustedes por su paciencia y a todos los colegas de medicina intensiva, anestesiología, nefrología de mi hospital, con los que durante años, han sido muchos, pero hemos trabajado con todos, codo con codo, en el cuidado de los pacientes críticos del hospital Ramón y Cajal que tuvieron IRA, y muy especialmente a la doctora Maite Tenorio y al doctor Antonio Gómez. Ambos han sido mi soporte durante muchos años y continúan haciendo una gran labor. Muchas gracias a todos.
Hello, my name is Sean Bagshaw. I'm a clinician scientist and intensivist from Edmonton, Canada. I would like to thank the organizers for the opportunity to contribute to this year's virtual Congress. I'll be speaking about big data and AKI. What can we expect? have these disclosures for 2021. I would like you to note, however, I am not a big data expert, nor am I a data scientist per se. There is no doubt we are living in an era of big data, and we are benefiting in one form or another from the technological and innovative advances that characterize big data. Big data really refers to the humongous volumes of data that cannot be processed effectively with traditional applications that exist. Big data is often described by its characteristics, its volume, its value, its veracity, its variety, its velocity, its virality. I won't go through each of those in detail, but just to give you some concept. Data science is the interdisciplinary field that uses scientific methods and algorithms and systems to extract knowledge and insights from many structured and unstructured data forms, including data mining, machine learning, AI, and big data. Data analytics, on the other hand, is the science of examining raw data, inspecting, cleansing, transforming, modeling, and various analytic techniques to discover new information, to inform knowledge, and perhaps inform clinical decision support at the bedside. In healthcare, there's no doubt that digital storage has become more efficient and cost-effective. So many, if not most, of our major healthcare organizations are now transitioning to digital health records. This is causing the datification, if you like, of health. So big data really seeks to bring new technologies and data acquisition, data integration, and analysis into clinical research, into hospital operations, and into clinical practice at the bedside. There may be many residual issues around the privacy of information and the ethical controls and oversight. However, there's no doubt that big data has the capacity to transform how we deliver healthcare. Indeed, the concept of learning from health records is not new, as you can see from this paper published in New England Journal in 1968. We are witnessing a transformation towards an integrated learning healthcare system through the use of big data and electronic health records. So in this trial, an electronic health record program identified and randomized high-risk patients for DVT-PE, and then sent an alert to physicians who had to acknowledge the alert and then who could decide to order or withhold prophylaxis. The primary endpoint was objectively confirmed DVT or PE. And the trial found that prophylaxis increased dramatically after the alerts were sent compared with the control group, and that these actually reduced the primary endpoint. So here's a great example of how a learning healthcare system can integrate clinical research to the bedside. Subsequently, there's been widespread evaluation and implementation of automated electronic alerting for several conditions, including acute lung injury, glycemic control, sepsis, and the clinical deterioration of patients on general medical or surgical wards. In recognition of this emerging datification in healthcare, we convened an acute disease quality initiative consensus meeting in 2016 in Banff, Canada on AKI in the era of big data to begin to explore how big data may transform AKI care. During this meeting, we had 5 work groups explore themes including predictive analytics, AKI detection in the electronic health record, the afferent limb of this, alerting, the efferent limb, if you like, the use of administrative data, and the concept of an AKI continuum across the healthcare system. I now wonder whether this meeting was a little bit premature, in part because there's been such a huge expansion in this field since we conducted it. As part of the ADCI meeting, we undertook a systematic review. We found that the evidence at the time on AKI alerts to improve outcomes was uncertain. We further concluded that e-alerts were significantly heterogeneous in design, i.e. detection algorithms, modes of alerting, degrees of intrusiveness of alerts, that e-alerts were variably implemented, so seldom formal education, training, or processes to ensure audit and feedback. And finally, e-alerts were seldomly included in clinical decision support. And if they were included, it was not context specific and it was questionably feasible. In the interim, though, in the last 5 or 6 years, several studies have described the use of machine learning and AI techniques for the prediction and detection of AKI risk across a spectrum of clinical scenarios. So in critical care, on the ward, in specialized surgical groups. These have varied widely, ranging from algorithms that are rule-based to more parsimonious and complex machine learning-based scores. Few have undergone broad and rigorous external validation. So this was one of the first, and I'll just give you an example. This used a machine learning algorithm to predict and detect early AKI. The machine learning algorithm was a boosted ensembles of decision trees to train an AKI prediction tool using an inpatient sample of around 300,000 encounters from 3 centers. So the AKI prediction tool used was a previously published algorithm from the NHS AKI algorithm in the UK. And they used a robust validation scheme in this study. In the end, the idea was to detect KDIGO guideline, KDIGO defined AKI, stage 2 or 3, in real time or within 12, 24, 48, or 72 hours prior to its onset. So what they found was that the machine learning algorithm performed better than SOFA scores per se, which has not really been validated for detection of AKI, at all time points. However, the performance declined as the prediction window increased. So it's unclear about the application of this. Could you integrate this into an EHR to inform decisions and alter perhaps patient exposures that would put them at risk for AKI? This would still need to be information that would reach clinicians, and this was not really discussed in this paper. So it's unclear whether this paper per se would inform clinicians on what to modify moving forward. So here's another example of a small single center study applying a machine learning algorithm to predict AKI in burn injured patients. They used a kappa nearest neighbor algorithm in a small data set, only 50 patients, to build multiple machine learning models to discriminate patients who would and would not develop AKI in the first week. The models really included things like NGAL, urine output, serum creatinine, BNP within 24 hours of admission. It found that it detected AKI with 90 to 100% accuracy in the first week, which is pretty unimaginable. Findings were generally that there was greater lead time with the machine learning algorithm than the urine output serum creatinine alone. So I think the study offers some example of how AI and machine learning may offer advantages over simple clinician recognition by using high automation, early classification of subtle changes or patterns via computer-based AKI recognition, rather than waiting for clinicians to recognize alone. So here's another example of a machine learning approach using gradient boosting to predict postoperative AKI in patients undergoing total knee arthroplasty. This was done in about 6,000 patients at 3 health centers. The algorithm identified 6 variables: postoperative serum creatinine, use of GA, male sex, ASA class greater than 3, use of a RAS inhibitor, and no use of intraoperative tranexamic acid. The AUCs were 0.78 and 0.89 for the detection of AKI in the derivation and validation cohorts, so modest to good. And the authors actually published their machine learning algorithm online for people to use moving forward. That being said, it's not been externally validated. This study was one of the largest and perhaps most rigorous machine learning algorithm studies performed to date. It's the implementation, external validation of a simplified version of a gradient boosted machine learning AKI algorithm. So the original algorithm had 97 input variables, whereas this one published in this paper had 59, so it was somewhat simplified, with the idea of prompting early nephrology consultation within the context of a single center RCT that's ongoing currently. So large retrospective study, 3 sites, aimed to predict stage 2 AKI within 48 hours of hospitalization. They did do internal and external validation within the 3 centers tested, included about 500,000 patient encounters. Stage 2 AKI occurred in about 1.4 to 3.4% of all hospitalized patients across cohorts, while renal replacement therapy was received by less than 1%. And the AUCs for predicting AKI ranged from 0.85 to 0.86, so modest to very good, actually. And for RRT receipt, it was about 0.95 to 0.96. So using a probability cutoff of 5.7% predicted stage 2 AKI a median 27 to 39 hours before serum creatinine actually doubled. Now, I want to emphasize, though, that this was conditional on serum creatinine, in fact, being measured. And I'll get to that in a second. But this cutoff at 5.7% showed the best sensitivity and specificity, which were 87 and 92% respectively. So this is another study done in New Haven in the US, retrospective study using a parsimonious model of 170,000 patients in 3 hospitals in the single integrated health system. They derived and externally validated within that health system. And they really focused on using routinely captured lab data to predict AKI within 24 hours of onset. So it had modest predictive ability for AKI, RRT, and death at 0.74, 0.77, and 0.79 for AUCs. But similar to prior models, it's important to acknowledge that the change in serum creatinine, as you see in the figure on the right, the change in serum creatinine is consistently the most important variable most machine learning algorithms describe, and hence this may be, susceptible to sampling bias. It would be dependent on us routinely measuring serum creatinine in all these patients for a lab algorithm such as this to work. This is a retrospective study looking at over 700,000 patients in the US VA health system that used a recurrent neural network, so a deep learning AI approach. This is the first study to use a deep learning approach such as this, to develop a continuously updated and accurate model to alert for the detection of AKI in real time during a hospitalization episode. Sensitivity was 56%, specificity was 83%, it was greater for renal replacement therapy. I think when we did the ADKey meeting, this was the original, sort of vision that we had for big data and being able to apply AKI detection algorithms and alerting within hospitalized settings. The lead time was about 48 hours here, and there were 2 false positive alerts for every 1 true alert, which is probably not too bad, depending on the actions taken by clinicians. So this is a far more complex approach, but it may be more interpretable, but it still does need to address the issue of clinical decision support. Finally, this was a single center tertiary study, randomized trial of hospitalized patients stratified by medical surgical wards allocated to a patient-level automated disruptive text alert sent to the covering healthcare workers, so residents or nurse practitioners or pharmacists, indicating a new episode of AKI occurred or standard of care, in which case there was no alert sent. The primary outcome was maximum change in creatinine, use of RRT, nephrology consultation, or death within 7 days. And you can see here that in the surgical subgroup, so overall, there was no difference in patient outcomes in the aggregate of the entire trial. But when you looked at the surgical subgroup, there was higher rates of renal consultation, dialysis, death and dialysis in those receiving the alert. So that's interesting. And the main challenge with this study was that there was risk of contamination between allocation within the wards and no directed clinical decision support to accompany the alerts, i.e. clinicians may be uncertain what to do. So there was a link to the KDIGO clinical practice guidelines in the page that was sent to clinicians, but in essence, it wasn't directed on what to do. So what may have happened in the study, and this is a theory, but that the alerts prompted more nephrology consultations in the surgical subgroup, and this may have prompted greater urgency to intervene at some level, translating into the higher utilization of renal replacement therapy and perhaps some attributable harm. Finally, this was a rigorous step-wedged cluster randomized trial of a multifaceted intervention that included an AKI e-alert, an AKI quality bundle, an education program, and hence integrated clinical decision support in 5 UK hospitals to evaluate the impact on processes of care, so AKI detection, quality of care, and patient outcomes, so 30-day mortality, lengths of stay, et cetera, at a health systems level. And the main findings were that this integrated multifaceted intervention didn't sort of move the needle on 30-day mortality or progressions of AKI, but did reduce hospital lengths of stay, did increase the incidence of AKI, and that's probably attributed to improved detection, largely through their educational program, but it also did show signs in improvements in the quality of care delivered to patients who had AKI. So here you can see this is a great example of an implementation science approach to improving care for patients with AKI in hospital. The last study I'll share with you is a great example of a thoughtful merging of quality improvement, implementation science, and a hybrid AKI alerting system and integrated clinical decision support to reduce the risk of AKI among hospitalized patients, and particularly hospitalized children. So this is a multi-center study done in the US at children's hospitals. And you can see here that the eligibility and exposure criteria for alerting was that kids would be exposed to 3 or more nephrotoxic medications on the same day, or an IV aminoglycoside for greater than 3 consecutive days. And what they basically found is if those kids were exposed, they were alerted to a pharmacist and the clinicians, they measured serum creatinines, they adjusted the medications, et cetera, and they found that this intervention reduced nephrotoxin exposure dramatically. It also reduced nephrotoxin-associated acute kidney injury and the number of days of acute kidney injury overall. So this is a highly successful example of an implementation science approach to improving quality of care in AKI. Finally, I think it's really important for us to recognize that we are all susceptible to alert fatigue. I know I can surprisingly ignore a variety of dull alerts that are occurring in my ICU settings and sometimes even my pager. But these 3 papers explore issues around alert fatigue, missed alerts, and the sheer excess of alerting that's increasingly encountered in clinical practice, and perhaps some of the approaches and warnings we need to take in how we design these systems to ideally improve patient care, but also to improve workflow for clinicians. So to summarize, AKI is common, it's increasing, contributes to less favorable patient outcomes and susceptibility to suboptimal quality of care. E-alerts can theoretically notify providers earlier of risk for AKI or overt occurrence of episodes of AKI. The available evidence has shown that variable impact of e-alerts in response to AKI on care processes and no meaningful improvement in patient outcomes or health services use, although there may be some, right? So the most recent implementation science approaches have certainly moved the needle a little bit here. But it's important to recognize that e-alerts are likely very context specific, and further rigorous evaluation is needed before widespread implementation, particularly around the piece of communicating the alert to clinicians and integrating clinical decision support about what clinicians who are perhaps not nephrologists or well-versed in AKI per se will do in response to the alert. And with that, gracias. I thank you for your attention.
Thank you very much. Muchas gracias, Fernando. Thank you, Marlies, for connecting and for the very nice presentation. Unfortunately, Sean is not connecting, so I guess there is a problem of timetable with Canada, with Alberta. So we have not much time for questions. I haven't seen a question. There is a question of Rafael Perez for Fernando, I guess. What is the dialysis technique of choice in the critical patient? At least for most patients, I should like to know the opinion of the 3 speakers. So maybe Marlies, you have presented the advantages and unadvantages of continuous, intermittent, and then maybe Fernando.
Yo creo que la que necesita el enfermo en el momento dado inicial, fundamentalmente basado por el estado hemodinámico del paciente. Con respecto a lo que ha comentado la doctora Osterman, yo estoy de acuerdo con ella en la magnífica revisión de la literatura, pero realmente no hay datos reales de cuál va a ser la evolución a largo plazo mejor para estos enfermos. Es más, tengo la sospecha de que, claro, el enfermo con insuficiencia renal crónica previa es más propenso a padecer nuevos episodios de fracaso renal agudo. Y ahí es donde no sabemos si la evolución hacia una peor evolución depende propiamente de la enfermedad renal crónica, más o menos el añadido adverso que pueda suponer la insuficiencia renal aguda. No sé si he contestado.
Okay. Marlies, what?
There is no evidence that one modality is superior to the other in terms of mortality, but I think both have advantages in certain and some risks. And for the unstable patient with hemodynamic instability who needs fluid removal, I believe a continuous mode is safer because there is the risk of hemodynamic instability is lower and you can remove fluid
more gently. But for patients who are hemodynamically stable, who can tolerate fluid removal, there is no evidence that either modality is better than the other. And I think in the end, the best modality is the one the nurses and the team are familiar with and can deliver safely.
Yo querría hacer un comentario. Estoy de acuerdo con la doctora Osterman. Yo creo que ahora hay una nueva oportunidad para las hemodiálisis intermitentes, que es la posibilidad de utilizar nuevas membranas con la diálisis extendida. Posiblemente ahí vamos a ganar mucho en estabilidad y en eliminar sustancias proinflamatorias. Yo creo que es otra gran oportunidad para contemplar el uso de las intermitentes en determinados pacientes en las UCIs.
Estoy de acuerdo. I would say that, si no te importa, Fernando, hablo en inglés. I would say that there is no evidence, but one area we should be very careful is the transition from continuous to intermittent. The patient who is supposedly stable, there is a recent paper by S.E.N, by his group, of patients who were transited from continuous to intermittent, and there were almost 50% with hypotension, and there were some predictors of hypotension, which was the vasoactive drugs treatment, and also too much volume left to remove. So this is very important in patients with continuous therapy, that we will be very careful to get rid of all the volume. But it's not good that a patient is going to stop a continuous therapy is still left with a lot of edema, and this will hamper and make it very difficult, the intermittent therapy. In this sense, Fernando, I would ask you, what about the techniques we use in the chronic patient about volume regulation and blood volume control to refine the volume that we remove from the patient at every moment? It's difficult to apply in the acute patient, but is there a future for this?
I think so, that there is a future. The time is the factor who is going to answer this question to us.
Okay, and leaving the techniques, I like very much your presentation, Marlies. I would say that a follow-up for patients with post-acute kidney injury, severe acute kidney injury, I think is a need. And I like very much the papers you presented. But I'm wondering, this was a recommendation for the CADIGO in 2012. So are we doing this? We still don't do it. I think you're right. There is no specific treatment to prevent the progression or maladaptive reparation, but detection of this patient and nephroprotection, control of blood pressure, albumin is quite important. It's important enough to see this patient after an episode. Do you think?
I fully agree with you. I absolutely agree. And it's such a simple thing. And I'm embarrassed, but it doesn't happen in our hospital because the nephrologists are too busy, and they believe that a family doctor, a GP, could do this, controlling the blood pressure and checking urine dipstick. And the family doctors are too busy, and they say nobody tells us that somebody had renal replacement therapy. So these very simple things are not being done. It's very sad.
We started to do this 1 year ago, and we just make a visit 3 months, as you finally told, 3 months, because it's the stage between CKD, AKD, or CKD. And we just follow the patient if it is necessary, but if not, we do some recommendation for the general practitioner and the renal risk and some dietary lifestyle recommendation, and that's it. It's just one visit. It's not that much.
Fantastic. Congratulations. That's really, really good.
Okay, Patro, have you a question for Fernando, for
Tengo
Marlis?
una pregunta para Fernando. Bueno, una pregunta y un comentario, Fernando, porque cuando ha hecho el estudio analizando la diferencia de costos de la técnica continua respecto a la intermitente, tú bien has dicho que no estaba incluido el factor humano, y es que yo creo que eso es un punto importante, ¿no? Me gustaría también que me explicara cómo lo hacéis, porque nosotros que somos un hospital como el vuestro, un hospital grande, yo hay veces que tengo alrededor de 9, 10 pacientes simultáneamente en técnicas continuas. Nosotros también estamos por la labor de integrar, o sea que hacemos técnicas continuas mientras el paciente está inestable, y en cuanto el paciente está estable, nos lo llevamos a nuestra unidad de agudos, donde le dializamos conjuntamente con otros pacientes. Pero si tuviéramos que dializar mediante técnica intermitente a 8 o 9 pacientes, necesitaríamos un arsenal de enfermeras para llevar a cabo esas diálisis. Nosotros lo hemos intentado y es que no nos sale rentable, porque una enfermera se pasa como 4 o 5 horas en una unidad de críticos con un solo paciente, mientras que yo tengo una sola enfermera para manejar los 8, 9 o 10 pacientes que tenemos en las distintas unidades de cuidados intensivos del hospital. Eso es lo que te quería preguntar. ¿Cómo lo organizáis vosotros en ese sentido?
Ahí es un punto crucial. Nosotros quizá en la unidad de agudos es la que no solamente trata a los enfermos en la unidad de agudos, sino es la que va a prestar asistencia en las unidades de cuidados intensivos. En general, nosotros las técnicas continuas programamos el tratamiento junto con los intensivistas, y las enfermeras van periódicamente cada 2 horas, mientras que, y si surge algún problema de manejo que no sean capaces, que lo son, de manejar las enfermeras de UBI, pues van allí. Y luego las diálisis intermitentes las hacemos a lo largo de las 24 horas. O sea que hay al menos, en general, 2 enfermeras por cada turno de 8 horas que se pueden desplazar. Hay momentos que es de sobrecarga, pero nos hemos apañado.
Sí, pero yo creo que si tiene en cuenta ese valor, ese coste humano, no hay tanta rentabilidad de una técnica respecto a la otra.
Es posible, pero ya lo planteaba el problema ese, que no se incluyó en ese precio el factor humano. Pero yo creo que vamos a tener que hacer otro para compensarlo. Y luego, además, ahora otro factor limitante era que no teníamos prácticamente monitores para técnicas continuas. Teníamos 4 monitores para todo el hospital. Ahora que los monitores han subido a 5 o 6, creo, lo del 6 ya no lo sé porque ahora estoy jubilado, pero sí permite que muchas veces las enfermeras puedan atender y que las UBIs han disminuido en número, han aumentado en volumen de capacidad de enfermos, pero han disminuido el número, que una enfermera a lo mejor pueda atender simultáneamente a 2 o 3 pacientes en tratamiento sustitutivo en las UCIs.
Si me permite, tenía una duda también sobre el manejo de los pacientes con COVID con técnicas intermitentes, porque tener a una enfermera dentro de una habitación de un paciente COVID durante 4 o 5 horas también lo veíamos nosotros un problema importante, ¿no? Mientras que con una técnica continua se entraba, se conectaba, se acudía a la alarma y no tenías que estar, porque con el EPI 4 horas metido en una habitación con un COVID es bastante duro.
Es un problema. Nosotros lo solucionábamos con 2 enfermeras y se iban turnando, lo cual era un coste de personal tremendo, pero en el COVID todo valía.
Claro.
We are talking about the logistics of nephrology attending the ICUs for continuous treatment and for intermittent. This is always a personal cost, and for physicians and for nurses. Yeah, I don't know how do you do it in St. Thomas and Guy's Hospital.
In here in our hospital, renal replacement therapy is delivered by the critical care team.
Mhm.
And that's very common in most ICUs in the UK. And the nephrologists get involved when patients are ready to leave the intensive care unit and need ongoing renal replacement therapy.
Okay.
But in critical care, it's delivered by the critical care team.
No intermittent dialysis in the ICU?
Very
Or-
rarely. So during COVID, we had to start because we ran out, and it was the first time we did this.
Okay, I think we are out of time. I would like to thank you, Marlies, for connecting, for joining, and for this very nice presentation. And also, Sean is not here, and Fernando, muchas gracias a todos. Y bueno, tenemos que cerrar ya la mesa. And Patro, si quieres decir algo.
Dar las gracias a los dos ponentes. Gracias, Fernando. Thank you very much.
Thank you.
Thank-
See you.
Thank you for the invitation. It's a great honor.
Thank you. Bye.
Adiós a todos.